prevention of obstetric violence. Before we begin, I would like to remind you, don't forget to use virtual background and on camera. I also remind you to give a webinar rule in the chat Zoom or in the WhatsApp group. Before we start the agenda, I would like to give you information about the schedule. We will start from opening, video from Ruang Bidan Indonesia, lecture about prevention of obstetric violence from Hazel Keedle, Q&A session, photo session, and the last is closing. Before we start the webinar, we will start with praying. Sebelum kita memulai acara kita pada pagi hari ini, sebaiknya kita berdoa dulu menurut agama dan kepercayaan kita masing-masing. Berdoa, dipersilakan. Cukup? Sesungguhnya tiada akhir dalam berdoa. Next session, we will let you know about Ruang Bidan Indonesia. For the operator, please help me to play the video. Thank you. Yeah, thank you for the operator. Next session, we move to the next agenda. In today's webinar, we have Midwife Hani as the moderator. Before that, I will read her curriculum vitae. For operator, help me to share her CV. Midwife Hani or Siti Hanisa Haira is a qualified midwife. She has educational background in Andalas University in professional program in Midwifery, Faculty of Medicine, also in Bachelor in Midwifery. She has also experience in several program, coordinator of Information and Communication Department, Bidan Initiator Sumatera Barat Organization. She also staff of Research and Education Division in Ruang Bidan Indonesia. She also co-assistant midwife, internship in clinical and professional midwife program. Research team in midwifery professional program, and enumerator also in Faculty of Medicine, Andalas University. She has several achievements and publications. Okay. So for Midwife Hani, are you here? Hello.
Hello,
Hello.
Midwife Anis. How are you today?
Hi, I'm fine. Thank you. Okay. Uh, time is yours.
Okay, thank you, Midwife Anis, and good morning to all participants. Welcome to Ruang Bidan Indonesia. Can you hear my voice clearly? Okay,
Yes.
so today we have another session, our Midwives Forum, Respectful Maternity Care series. Specifically, today we will discuss the prevention of obstetric violence. My name is Hani, and I will be moderator for today's informative and engaging lecture with our Hazel Keedle, our lovely speaker. So, dear participant, we are thrilled to have you all join us today to explore an important topic in midwifery, which is respectful maternity care. Before we continue, let me give a quick overview of what we have for you today. Firstly, an opening and introduction from Ruang Bidan Indonesia. Secondly, we will have expert panel discussion by Dr. Hazel Keedle. Thirdly, Q&A session for evaluation. And lastly, we'll have a closing remarks. For all participants who have a language barrier or having difficulty in understanding the materials, you can message us. You can tell us also, don't feel shy, don't feel hesitate to contact the committee. Untuk para peserta yang kesulitan berbicara dan memahami materi yang disampaikan, nanti bisa jangan sungkan untuk menyampaikan ke panitia, melalui chat box juga bisa, melalui resen juga tidak apa-apa. Silahkan untuk dilaporkan saja ya. Okay, now let's move to our second topic, prevention of obstetric violence. Today we have an expert who dedicates herself to the VBAC topic. Hazel not only talked about on the theoretical things, but she was a VBAC fighter herself. She also a midwife, author, lecturer, researcher, director of academic program Midwifery, School of Nursing and Midwifery, Western Sydney University, Australia. I'd like to welcome our distinguished speaker for today, Dr. Hazel Keedle. Hello, Hazel.
Hello, thank you for having me back today. It's wonderful to be here.
Oh, good morning from Indonesia, and it's already afternoon in Australia, isn't it?
It is afternoon just, yes.
Yeah. Okay, you look so lovely. How are you?
I'm good, thank you. I'm good, thank you. How are you today?
I'm very ecstatic. Thank you for taking the time to share your knowledge in our webinar. And you will have approximately 50 minutes presentation and further Q&A discussion for 30 minutes. We can't wait to hear your story and experiences. So now, without further ado, let's listen actively to her speech. Hazel, the forum is yours.
Thank you very much. I'll share my screen. So today I'm going to talk to you about obstetric violence. It's quite a powerful topic, and it might be quite a difficult topic to listen to some of the information, especially when I share quotes. But I think it's important because to really be able to provide respectful maternity care, we need to understand what it isn't. And what it isn't is obstetric violence. So I do want to give you a trigger warning. There is, we're going to be talking about some powerful situations. We'll be mentioning trauma and sexual assault. And so if this impacts you in any way, then, please reach out or look out for some support for yourself. Maybe do something that's completely different after your presentation, after this presentation. Maybe go for a walk, hug your children, and speak to your friends. Do something for some self-care for yourself after this presentation. I'm also going to start with a statement. And this statement really helps me stay clear to why I talk about obstetric violence and why it's important to me. because I believe that all women deserve respectful maternity care, free from harm, abuse, and disrespect. I want to start off with telling you where this data comes from, because the information I'm giving you is actual research data. Now, last week you found out all about me, about my time in Indonesia, my time of having my own babies, and then one of them being a VBAC, and my route to my PhD, and the work that I did for my PhD, and that was the vaginal birth after Caesarean study. But after my PhD, I was lucky enough to have the opportunity to take on a brand new study called the Birth Experience Study. It has an interesting background. Over here in Australia, we had some filmmakers make a documentary called Birth Time. I really encourage you to look it up. You can stream it online. And it was a midwife, a doula, and a TV personality in Australia who worked together to create this film and travel around Australia and find out what's going on in maternity for women in Australia at the time. This is just pre-COVID. Then the film came out in 2021, and they reached out, the producers reached out to Professor Hannah Darling and myself to say they'd love to have a survey that goes alongside the film. Now, we thought maybe it would just be a small survey, but when I get an idea in my head, I like to take it big. One of the things that was really important for us was that it wasn't just designed by Hannah and myself as the researchers, but that we used co-design principles from the very beginning of the survey. After all, the co-design principles started with filmmakers. So in Australia, we have a bunch of different maternity consumer organisations. They're activists, they're educators, they're midwives, they're doulas, and they come together with lots of different backgrounds, lots of different beliefs, but with the sole aim to make maternity care better for women in Australia. So we reached out and we asked them would they like to be involved in the co-design of our survey. And a member of each of the organisations you can see on the picture one member came from each of those groups to join a consumer representative group. They helped us design the study. And it's important that I tell you that, because the questions weren't just from ourselves as researchers. Since then, we've been working on the data, and the survey was out for 9 months in 2021. And then we have had some summer and winter scholarships. So at our university, Bachelor of Midwifery undergraduate students get the opportunity to work with us as researchers during the summer or winter terms, and they get paid for that scholarship. I've got a medical student working on a really interesting medical project as part of the Birth Experience Study. And next week, you'll actually hear about some of her data. Oh, I've also had 2 psychology honours students who did their thesis on data from the Birth Experience Study. And then we even had a Fulbright scholar come from the US on the very prestigious Fulbright scholarship to work with Hannah and I on some aspect of the best data set. So it was live in 2021, like I mentioned. We ended up with 8,804 responses from women, and they're the ones that had done 75% completion. We actually had 12,000 hits on the survey. From all those completed, the 8,804, we ended up with nearly 55,000 comments responding to the open text questions. So we had a variety of validated tools like art scales, yes and no questions, list questions, but then also open text questions, and that's where we've got those nearly 55,000 comments. That's a lot for us to go through. The survey covered all sorts of things: pregnancy, labour and birth, interactions with clinicians, decision-making, respect, postnatal care, and breastfeeding. And we're now in the midst of the data analysis. We've already had 3 papers published. This one, the last one, BMJ Open, literally just last week, I think it was, or the 7th of September, whenever that was. This first one was a poetic inquiry on traumatic birth. I'm going to tell you a little bit more about that next week, and even share some poems with you next week about birth trauma. This was our next paper, Dehumanized, Violated and Powerless. And this is the obstetric violence paper that we're really going to dive deeply into today. And then we had one in BMJ Open, which is what women want if they were to have another baby, the Australian Birth Experience Study, Cross-Sectional National Survey. And this was a really interesting paper on, we asked women, what would you do differently if you were to have another baby? And this one had the biggest amount of comments. I think it was over 6,000 comments, or 6,101 comments on what they would do differently. So that's a very fascinating paper. We also have 2 papers under review. The one that was led by the Fulbright scholar Helen, and one on the methodology, because I've actually written a paper on the co-design and the social media strategy that we used to get such large numbers. And now we've grown from a little acorn, we have grown into a big tree across the world, and we have 12 research groups using our survey and working together with us as a collaboration to really explore women's experiences of maternity care in their own locations. And as you can see, there's a little dot there for Indonesia. So a special shout out to Diza at Universitas Erlangga, who is leading our Best Indonesia team. And so please feel free to contact her. She said that was okay. If you are interested in being part, I think it will be more than just one university. I think you'll actually have a collaboration within the collaboration. So do reach out to Diz if you have more information. And as her survey, so as the Best Indonesian survey becomes translated, go through ethics, and then once it's live, we will be looking to you from the Ruang Bidan to share the survey on your own platforms and with women, so that we can actually hear what are the maternity experiences of women in Indonesia, which I think is very important, and I hope you'll be very excited about. So let's get on to what obstetric violence then. Let's talk about it. Let's look at what it is and what it is that we can then do to prevent it as well. Now, birth trauma and obstetric violence might be 2 confusing terms. You might not really understand what is one and what is the other. And I haven't seen very many good definitions out there that really incorporate and understand it. So I kind of came up with my own concept. And that concept is that birth trauma is an umbrella term. And really, it's probably better described as perinatal trauma, but that's not a recognized term. So let's use what people understand. So birth trauma, I see as an umbrella, has lots of different types of trauma sitting underneath it. And a woman can experience one, or she can experience all, or she can experience a variety, to then have had a traumatic birth. Remembering, though, it is not for us to say to a woman, your birth was traumatic, but it's for a woman to realize that her birth was. So some things that come underneath that umbrella that we will explore in more detail next week is that loss of control, a fear for her own life or a fear for her baby's life. Maybe physical trauma, so that can be perineal trauma, but why not also Caesarean scar trauma? There can be that lack of support, and we really saw that happen during COVID, didn't we, when women weren't able to have their support people come with them to hospitals. And then part of that is obstetric violence. And I think it's a particularly damaging type, because this is where women experience violence and mistreatment from a healthcare provider to themselves. Now, in our survey, or in the Australian side of the survey, we found 28% of women experienced birth trauma. And throughout this presentation, there are some examples of comments like this one here. I'm just going to hide my video panel. Oh, wrong one. Sorry, just one quick second. There we go. Okay, now I can see my full screen. Sorry. It says, I felt ridiculed at times. I felt disempowered. I walked away feeling less like a woman and left to mother my new baby and my other 2 young children. I think quotes are really important for you to understand what women are saying about birth trauma and obstetric violence. So this was a comment under the birth trauma question. We asked women, was your previous birth traumatic? And if they said yes, they got the opportunity to leave a comment. Over 3,000 women left a comment for birth trauma. And we're still going through that data, and we've had a student look at it. Oh, now my slide thing's gone. No, who is? Okay, the other thing I just want to talk to you about as well is the mistreatment index. Now, like I said, our survey had a combination of validated tools as well as questions, yes, no, a list of questions, and open text. And this is one of the validated tools that we used. And I think it's a really important new tool that came out of Canada. It's a series of 7 items, and you can see those in the green box. And they identify different types of disrespect and abuse by maternity clinicians. And then we asked women this question or these statements. And the item with the highest yes responses was being ignored, refused requests for help, or failing to respond to requests for help. This was followed by the withholding of treatment or forcing treatment, and then being shouted or scolded at by a healthcare provider. And although the other items have fewer yes responses, the fact that 77 responses, actually this is just for New South Wales, there's more for Australia, indicated that they'd experienced physical abuse such as aggressive physical contact or inappropriate sexual conduct, is obviously a cause for concern. There's one quote: the feeling of being forced to remain on my back while labouring, being physically pushed down on the bed. Now, as you can see from these 7 statements, they're quite varied. But when we say a woman has experienced mistreatment, they only have to have said yes to at least one of those 7. Now, many women said yes to more than one, but to have a positive mistreatment score, they just had to have one. And we found in our survey that 35% of women had said at least one. 18% felt ignored by clinicians, and 2% experienced that final one, that physical or sexual abuse. What's interesting is this 35% is actually higher than the birth trauma rate, and also what I'm going to show you next, the obstetric violence rate. So where we say we think those rates are actually underreported, I think the mistreatment score shows that it is, and that 35% have an experience of mistreatment. In our international study, we are using all of those questions, but including the mistreatment scale. And one of our countries, the Netherlands, has already got their data. They've done a survey last year. And they found that 20% of women had a positive mistreatment score. And it's going to be very interesting when we do this in all the 12 countries to see how this mistreatment score varies across the different countries. And I wonder what the mistreatment score will be in Indonesia. So from yourself, I love you guys chatting to me. So from you looking at those 7 statements, what do you guess? What do you think might be the score for a woman experiencing one of those in Indonesia? I'd love to hear from you, so pop it in the comments. Oh, and thank you, Ernie, for sharing the birth time movie as well. So I might just see if we get any comment, any guesses there with the statistic. Throw some in there. I'll carry on talking, but I'll keep an eye on the chat. So in the survey, we then also did ask, did you experience obstetric violence? And we did put a definition next to the question, which was the mistreatment or abuse by a healthcare provider to you, to yourself, or to your body. And that was a definition that we got from the United Nations. Now, a few years ago, the United Nations actually got a special repertoire to do a report on obstetric violence, and they found that it was common all over the world. And because of that, they said it was a gendered violence, and it's an internationally recognized term. But there is some disagreement here in Australia about using the term obstetric violence. We have our medical colleagues in our medical colleges who are saying that they don't like the term obstetric violence because no doctor ever aims to be violent, and that it's an alienating term for doctors. But what we have to recognize with this is not to take it, not to be defensive. And when we have these colleges coming out with these defensive terms, then it's trying to distract from what the actual problem is. The definition of obstetric comes from the word meaning anyone who is there at the birth or who's assisting the woman with the birth. So traditionally, that would have been midwives. So obstetric for us, and for the term obstetric violence in the international arena, is any healthcare provider who is there during the labour and birth. And actually, we found that it wasn't just labour and birth. It was also during pregnancy and in the postnatal period too. So please don't go away thinking that obstetric violence only means violence by obstetricians, because it doesn't. It means violence perpetrated by any healthcare provider, and that includes midwives, that includes nurses, maybe radiologists, maybe sonographers, maybe healthcare people in the team that they're going to see. So just to get that right. Now, when we ask that question, now this question, remember how I said that some of the questions were designed by our consumer organizations. Well, one of our consumer groups, Human Rights in Childbirth, which is an international human group, a childbirth activist group, they asked for this question to go in. So you can really see this was a co-designed survey. We'd never asked this question before in Australia, so I really was unsure what we would find out. And what we found was 991 women responded yes or maybe. Now, we threw a maybe in there because we were not quite sure if women would really understand the term or feel comfortable saying yes. Then we asked them if they said yes or maybe, could you leave a comment? And 626 women wrote comments. So what that ended up being is that more than 1 in 10 women in our survey, which was representative, well representative of Australia, experienced obstetric violence during their maternity care. Here's a quote from one. Obstetrician pulling my placenta out aggressively without telling me the option to birth it, telling me to be quiet. With those 626 comments, we did a content analysis, a qualitative content analysis, and we found that we could group them into 3 main categories. And they were, I felt dehumanized, I felt violated, and I felt powerless. So let's have a look at what kind of subcategories and comments came out of those main categories. I didn't see anyone guessing any percentages. It would be interesting to see if you can think how many you think, or even how many do you think women will have experienced obstetric violence in Indonesia? Do you think it's the same at 1 in 10, or do you think it would be more? So here is the categories table. And what this shows you is the main categories, then the categories, and then on the side you can see the numbers of comments and then the overall coverage of those. So the number of comments in each of those categories and the overall comments around that. So I felt dehumanized had the most amount of comments, as you can see there, 58%. And that was broken down into comments around disrespect and abuse, comments around I was nothing to them, just a number. And that really looks at the depersonalization of maternity care, feeling like There's no individual care, that people don't really care about you. There were comments around my pain wasn't real. So calling out for pain relief, asking for support with pain during labour, and being neglected and ignored. And the ongoing trauma for both of us looked at the impact of birth trauma, or obstetric violence, on both the woman and her partner. So they were there with them, by their side, and also watching the episode of violence happen. I'll jump to the I felt powerless, which was the smallest one. And that's where the example, you have no data, so no ideas. It's an uncommon term. That's right, it's an uncommon term. But I think even just reflecting from your practice, are you, like, especially when you read some of the comments, is there anything here that makes you think, yes, women are experiencing this? So that I felt powerless, there were comments around feeling coerced and coercive language, such as, if you don't do this, your baby will die. And we touched on that a bit last week, didn't we, with the VBAC hurtful comments. I was uninformed or misinformed. So not being given all the information, by maybe exaggerating the facts or exaggerating the numbers of what might happen and not giving all the information. Or feeling forced into having interventions, maybe being coerced and forced into having an induction of labour or an epidural or or pain medication or a rupture of membranes, or these interventions that we use every single day, but do women feel that they're being forced into them? And then I guess the most distressing category is the I felt violated. And there were 3 subcategories. One of them, fingers were inserted into my vagina without consent. I'm going to dive into that a bit more when we look at the comments there. But that was, as you can imagine, vaginal examinations. There's physically manhandled, and that was actually physical abuse. So that could be a very painful fundal rub of the fundus after the baby has been born, but not actually getting consent for that, or even explaining what it was that the midwife was going to do, and just doing it really, 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 really roughly. Or it could be the grabbing of breasts during a breastfeeding demonstration. Then there was a category on episiotomies. And in Australia, we are seeing a rise in our episiotomy rate. And that one was, I begged the doctor not to cut me. So here's one of the quotes on the dehumanization. And she gives 3 reasons. I felt dehumanized because A, nobody told me the procedure was optional or gave me the choice to opt out. B, I was very clearly highly distressed and they didn't pause or stop the procedure to check my consent. And C, there were 3 people I didn't know standing and looking at my exposed naked body. And D, the midwife had joked about the procedure. Now, I'm going to ask you for some feedback, and I'm going to ask you, from all of that comment, which bit shocks you the most? Which part of the comment feels most shocking or most challenging to you reading it?
Well, for me personally, I think it's when the midwife had jokes about the procedure. But to be honest, if you asked about the number in Indonesia, I can say it's quite common. I mean, like, based on my experiences as an intern student back then, like past few years, and it's very devastating. Like, I used to like discuss with my friend about this matter.
Yeah. Thank you, honey. Yeah. Anyone else on what part of the comment really stands out for you? I think all of it is quite challenging, isn't it? There's, in A, you can see there's a lack of informed choice because she wasn't given an option to say no. There's the fact that in B, she was very distressed and no one stopped or paused or even checked that she'd given consent. And then having 3 people standing and looking at her exposed naked body, feeling so violated in that way and feeling so vulnerable in that way. And then the fact that the midwife had joked about it as if, you know, it doesn't matter. And does it matter to you that we don't know what the procedure is? Is that important? I don't think it is. Because I don't think, however urgent or emergent a procedure is, it should never be experienced like this. So we might, as clinicians, and I know I've been a clinician for 20 odd years, we sometimes want more information. We want to look at that and go, oh, but what was it? What was the procedure? So maybe we can justify it in our head. But what I like about this comment, not that there's much to like, but what I think is powerful about this comment is that we don't know. And then we realize, well, I realized it doesn't matter what the procedure was, because this is how the woman felt. And that's not okay. Here's another one. They didn't care what damage was done to me or my body. They just wanted the baby out. I was a vessel. How does this make you feel? I was a vessel. What kind of things is she saying in this comment? There's the dehumanization, that she doesn't feel like she's seen as a person. Almost like this vase. She's carrying a baby and the baby's going to come out. And that was more important, she felt, in the healthcare provider's eyes than anything that happened to herself. But the woman is at the center of this care and shouldn't be feeling like she is only there to deliver a baby and is not important. Because we know as midwives that mothers and babies are a dyad. They are part of the same thing. They are the same. And if we have a broken mother, we have a broken vase, who's going to support that flower? Who's going to support that baby? It's not just about getting that baby out alive, which obviously is a big, big motivator. But it's how can we ensure that women come out of this and thrive? Because it's the women who are going home and caring for that baby, bringing up this baby, bringing up the next generation. And they shouldn't be feeling less of a mother, less of a person, or a broken vase because of what was done to her during birth. I said no to the offered intervention over 6 minutes of repeated asking. I finally said yes when she coerced me by getting me on my back with anesthetic drawn up on a needle. I never gave informed consent. So our brain is probably trying to figure out what happened. She didn't say, I'm kind of thinking maybe an episiotomy. I can't really think what else would be there with the anesthetic. But again, does that actually matter? What we can see here is that woman just kept saying no, she didn't want it. And then she felt she had to when she was coerced by the person doing it, by the healthcare provider. But she never actually gave informed consent. It was coerced consent, which is not consent. How does that make you feel? Is this something that maybe you might have seen? People doing this kind of thing without really getting consent or really getting informed consent. In the care that you may see, do you sometimes feel that women are being pushed into agreeing to things? Because from the woman's point of view in Australia, this is obstetric violence. The vaginal exam, where I did not consent, that went on for over 5 minutes, as I was held by my wrist and told to sit still and be a good girl, while I yelled no and to stop repetitively while moving up the bed. This is a very strong and difficult comment to read and to hear, but it wasn't a rare comment. There were examples of vaginal examinations with this kind of wording. And I think if we read these comments without realizing it was an internal vaginal examination, we may well feel that they were describing sexual assaults, because that's the language that was used. I'm just going to quickly open something because I want to just read some of the comments that I listed, not the comments, the words. So I've just put it up. Here we go. So I'm writing the paper. Included in some of the comments were words that could be associated with sexual assault. And I'm going to list them now. Penetrate, shoved, probing, rough, aggressive, violent, ripping open of legs, violated, torture, and raped. That's really shocking, isn't it? To think that people could be saying that about a vaginal examination. And I wonder, in Indonesia, do you also have a 4-hourly vaginal examination policy where you're expected to do them so often? So Ernie says, what do you think about procedures performed under the pretext of saving lives? Well, we'll get to that at some point. We will get to that. Yeah, when a midwife said these comments. So it's really quite challenging, isn't it, to read that and go, well, what can I do about that? Why are women experiencing vaginal examinations like that? And what can we do differently? And I do have some suggestions that we will look at shortly and what we can do differently. So here are my 3 things that I think we need to identify and to work on when we come at addressing obstetric violence: reflection of practice, respect education, and OV legislation. Some of them we can do personally, some of them we need to work together and combine and advocate for. Another thing I quickly want to go on before I talk about that reflection of practice is that it is different. These rates are different depending on the different models of care that women experience. So when we looked at our birth experience study data, we separated it into different models of care: standard GP shared, private obstetrician, midwifery group practice, which is continuity of care in the public model, and privately practicing midwives, which is in the community model, but women have to pay for that. It's often home birth. And if we look at obstetric violence, which is the purple, and this is the standard line, the light purple, things that are above it are that fragmented system where they're seeing a different person every time. They don't know who they are. But what protected against it was relationship-based care, when they're having continuity of care either with a doctor or with a midwife. So there are things that we can do, and that's why it's so important that we understand the impact of our models of care. So let's talk about vaginal examinations. They can either be an intimate internal examination that is done with informed consent and done respectfully, or they can be a sexual assault. So how do you do them? And how do we ensure that we're not crossing over that boundary to sexual assault? Now, in Australia, this is not well talked about. And really, some of the research that we are doing, we are the first people to kind of talk about it. Even in the obstetric violence literature out there, this is not being discussed. And I think it should. We know that so many women are coming through to have babies who have a history of sexual assault. And in Indonesia, maybe those numbers are not even reported. Maybe there's much, much higher than we actually know. But then if we've got that history, regardless of if you've got that history, you're then experiencing vaginal examinations that can either remind you of that sexual assault or be a first-time sexual assault. We have to ask consent. We have to take it slowly. I often think that if I had a magic wand, it would be that every healthcare provider, before they're about to do a vaginal examination, they stop and they think, how can I make this safe for the woman? Just do that. Stop before your next one that you do and go, how can I make this safe for the woman? And that might be sitting down on a chair next to her and explaining what it is that needs to be done, not towering over her over the bed. Sitting down and explaining the risks and benefits and alternatives to having a vaginal examination. Giving the woman choice, and that's really important in trauma-informed care. Who would you like to do this internal examination? Where would you like it done? Would you like someone to hold you while it's being done? And give stopping parameters. So what I mean by that is you can, as you say to the woman, if at any time you want me to stop, just say stop and I will stop. But too often, those words are empty. I've seen it. People will say, oh, we'll do this examination and just tell me to stop and I'll stop. And then they're mid-examination with their fingers inside and the woman's like, stop, 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 stop. And they're like, oh, just a bit longer, just a bit more. I'm nearly at the head. Let me just check a bit more. You have just violated the agreement of stop. So you need to give those boundaries and then stick by those boundaries. But also think, have you got full consent to do everything that you're going to do? Are you going to rupture the membranes? Are you going to continue an examination during a contraction? Are you going to fit a scalp clip? Did you get consent for any of those? If you didn't, what you're doing is an assault. So we have to think about vaginal examinations. There are some amazing respect workshop information out there, and this is from our very own International Confederation of Midwives. You can go online onto the ICM website and you can download their entire respect workshop toolkit. And you can set this up in your hospital, on your maternity department and say, let's do a respect workshop. They've got all the videos there, all the PowerPoints. It's all there ready for you to use. It's got all the facilitator guidelines. You could sit and do this with your team. If you want to make it really impactful, though, make sure it's not just midwives. Get your doctors along as well. Get your nurses along. Whoever works in that space, do an interdisciplinary workshop, because then you learn from each other. And I love doing those types of workshops. They're so fascinating. So you don't need to make stuff up. This is already available. Download it, have a look at it, and I challenge some of you to run this. I challenge those of you that are lecturers, run this with your students. When you have done it, can you please let me know how it goes? Because I'd love to hear how you found using the Respect Workshop Toolkit. Please do it. You will see a difference. And then lastly, obstetric violence is gendered violence, and women should be protected under legislation. Now, I don't know the legislation in Indonesia to protect women from intimate partner violence or domestic violence, or what your violence against women and children rules are even like. But here in Australia, obstetric violence at this point is not recognised as a form of gendered violence. But we are working towards changing that. We met with the New South Wales politicians, and we now have this birth trauma inquiry right now that's happening. And within the terms of reference is legislation around this. So maybe we will see change in the future. But bear in mind, this is not unachievable. And do you know that 7 of the 11 countries in South America have legislation against obstetric violence? If they can do it, we can do it too. And what would that mean? Well, I'm sure you know many practitioners that are worried that what if we're like America and women start suing us for bad outcomes? There's a fear, isn't there, that you might get sued, someone might take you to court if there's a bad outcome. Now that's because there's legislation. But if there's legislation for obstetric violence, maybe the thing in the head will be, if I do cause obstetric violence, I can get into trouble by the law. That can be a good motive to be thinking about how not to do obstetric violence. If you want to read more on the paper, then please scan this now. This takes you to open access, so you can read it. Anyone can read it online. It was led by myself, my husband as the research assistant, and Professor Darlin as well. So the 3 of us wrote this paper. And it was published in December last year, so it's still very, very fresh. It's a difficult read, like the comments that I've included in this presentation, but I think it's really important. And in the discussion, we call for change and how to bring about change to prevent this from happening in the future. So I'm going to ask you now, until you go back to that statement I said at the beginning, that I believe all women deserve respectful maternity care, free from harm, abuse, and disrespect. Do you? That's it from me. I think I've given us plenty of time for a chat, which I think will be really important. I will see you next time when we do finish. Please do follow me back on Instagram if you are not at this point. I'm always popping up new research and new research papers that we're publishing, so have a look at me on there. But otherwise, I'm now very keen to get back to having a chat.
Wow, that was heavy, Hazel. Like, it is true when you say it will be a trigger warning for everyone here. And I personally also feel so devastated to know about how this small action can be so huge to the mother and give a long-term effect to them. Yeah, it's surprising to know that this rate of obstetric violence show a common trend. Yeah. It's not humanized because they are not given the opportunity to make a decision, feel embarrassed. It's surprising me because I found it quite common in the clinical setting back then when I was in university. It's actually make me questioning about it. It's not something that I used to believe as a midwife should be, but it's the reality. We have covered all the critical topics now, and for the participant, if you want to have opportunity to have discussion with Hazel, we encourage you to raise hand and turn on your camera, turn on your microphone. You can ask directly, or you can write down in the chat box, please, because this is very close to us. I believe each one of you wants to say something about this matter and how to solve this. Okay. Okay, I will wait. Whoever wants to ask directly. Okay, while waiting, I think I want to give questions from the registration form. Is that okay, Hazel?
Yes.
Okay. Okay. So one of the question is, I'm so interested in this topic based on the reality we experience and meet various types of midwife. And I believe one of it is the furious midwife who has problem in managing emotion. It is an awful truth that we saw mother being yelled at during the labor or many more. And I believe people who attend this event, they are who aware to that type of a practice, but based on your perspective, what should we do to raise awareness about providing midwifery care that respect women's rights, especially among midwives who are still ignorant to this matter, or maybe those who are already senior or have power, so we hardly tell them. How can we engage to this matter?
Absolutely. I think your actions always speak louder than your words. So purely by being that kind midwife, being the one that listens to women, gives them choice, gives them consent, asks for consent, doesn't shout, is not a bully. Just by your actions, your kind actions, you are making a difference. You are making a difference to the women that you speak to, but also the culture that you work in, because the students who are then seeing the difference between a furious, angry midwife and a kind and compassionate midwife are going to be able to model themselves on the kind and compassionate midwife. And they're intelligent as you were to sit back and go, that's not how I want to be. I don't want to be angry. I want to be kind. And so your actions of doing that are really important. And as you go through your midwifery career, and if you end up in those leadership positions, then you also need to work on actively creating a culture in your workplace that is kind and respectful to everyone, and most importantly, to the women. And that could be bringing in some respectful training, or calling out a midwife for being angry and saying that is actually against your midwifery practice and should not be happening. We can't allow poor behavior to stay in a workplace because it has a negative ripple effect. But what we can do when we can't control that is we can counteract it by being the kind one, being a midwife that people look up to and want to be like and model, so that eventually that modeling can take over and the more furious, angry midwife stands out even more.
Okay, so there should be like a regeneration of the midwife here who should give an example, a right example of how to treat mother. So yeah, it's very like complicated also, I believe, since we have like sometimes some kind of hierarchy in a workplace, so it's a bit hard. Yeah, it's really complicated.
It's not easy. And I have, I have worked as a, when I was a junior midwife, and seeing some behaviors that made me feel very uncomfortable. And it's difficult what you can do. But I guess you can't control, as a junior, you can't control other people's behaviors, but you can control yours. And you ensure that that's not the kind of person that you become. And, is it also thinking, why is that midwife like that? Is she stressed? Is she overworked? Does she not want to be there? And making sure that you don't go down the same path, that you actually look at your self-care, that you ensure that you're being well looked after, that you look after yourself, that you don't get to the point that you are also that angry midwife.
Yeah. For a question here from the chat box, from Erni Rosita Dewi, what do you think about procedures performed under the pretext of saving lives? For example, in the case of VBAC, there is a time restriction to stop bleeding, so everything has to be done quickly and sometimes without consent.
Well, I understand that, the full informed consent, can take a little bit of could take a time. But as a midwife myself working in those emergency situations, there is always room for communication and for kindness. Being able to look at the woman and explaining what needs to happen can be done very quickly. It can be, I've noticed that you're bleeding and you're bleeding quite severely, and I need to get a team of people to come in here and help us manage that. That's also going to mean somebody might be rubbing on your tummy quite hard. Other people will be giving you injections, and there'll be other people in the room. I'm really sorry this is happening, but are you okay if we continue with this? Just a quick overview, just a quick comment before people start running in the room, or as they start running in the room. Acknowledge what's going to happen and keep the woman there. Another good thing that I often teach my students is, if the student feels that they don't really know what to do in an emergency, then they should go to the woman's side and explain to the woman what is happening all the time. That is much better than having a student in the background going, oh, I don't know what to do, and running out the room. They could instead sit with the woman, stay by the woman's side, hold her hand, look around the room, and believe that student has more knowledge about what's going on than potentially the mother. So then explaining to the woman and to the partner or support people, there's a lot of people in the room right now. I can imagine that's really scary, but they're all here to help you. That person over there is doing this at the moment, and they're a doctor and they're doing this because of this. Your baby's over here, I can see it, your baby is fine. Are you okay? Like, how are you feeling? Checking in with her all the time, keeping that communication going. It's actually quite important in a PPH, because although you're dealing with the blood loss, how the woman is coping with that blood loss is actually really important. And if she has someone next to her, she says, I'm feeling really faint right now, and she's got someone to say that to, then that might trigger the people to go, oh my gosh, we need to put oxygen on her, we need to lower her, she's going into shock. Whereas we know that she might not have bled so much, but she's getting a big impact. Some women can bleed a lot and not go into shock. It's quite strange, isn't it? But having someone just allocated to be by their side and explain what's going on, then it's not seen as much as a traumatic event. And it's not seen as so much as obstetric violence, because there is someone in there keeping that communication going. So I think that's a really good idea to focus on having someone sitting with them. But if you haven't got that, there's not enough of you to be able to share, to have someone doing that, just getting eye contact, I'm giving eye contact to the camera, just giving eye contact, giving a smile, staying calm, and just explaining what you are doing will help prevent it from being seen as a traumatic event. Does that help, Ernie?
Yes, thank you, Hazel. So maybe I have another question. I'm interested when you say that initially you got like rejection when you are used obstetric violence, but I think we should make everyone recognize about it. So what do you do when you get like rejection from medical college or your midwife? Yeah, because it's
Well,
very uncommon. Yeah.
yeah, it's an uncommon term. But as my colleague, Professor Hannah Darling, said in the public arena of the inquiry recently, it wasn't that long ago that in Australia, the term intimate partner violence or domestic violence wasn't seen seriously. And the media would joke about women being bashed as if it was okay. And now we know it's not. So we just have to stick with it and see the change, and not try and get distracted by looking at different name terms or how it can offend people. Because where I go back to clinicians and they ask me, I don't really like the term, I then go back and say, this is distracting. It is what it is. It is obstetric violence. And as uncomfortable as you feel with the term, it's nothing like the pain and trauma of the women who have received it. And we have to keep that at the forefront. I go back to the comments that are in my paper and I read them and I still get shocked by them. When I closed the survey in December 2021, the first data set that we looked at was the obstetric violence comments. And there was a reason behind that, because when I read those comments, I sobbed. I was so upset and shocked to hear these comments. And therefore, I had to think what it was like to write them. These were women across Australia who were doing a survey. They didn't know they were going to be asked that question. And when they were asked that question, they were honest. And they almost ripped open a wound of their heart and bled those stories into the survey. And therefore, as the researcher, it was my job to honor those voices, to honor them and realize how much they did. Because once they shared their stories, they patched themselves back up and carried on looking after their children. And that is bravery. So when clinicians or doctors or midwives or doctors have a go at me about the comments, it can't touch me because I know what touches me. And that's the bravery and the strength of the women that share their stories. And they're only doing it to make life better for other women. And I think that is the biggest strength that we've got. Thank you, Annie.
Okay, I want to encourage the participant here who wants to ask question directly. You can raise your hand, or you can write down in the chat box also.
And Annie, you even mentioned the nipple stimulation as an excuse to stimulate uterine contractions. So is that midwives doing that to women? Yeah, that's very violent, isn't it? That's very violent. Yeah.
But it's really interesting, Hazel. Like, to be honest, I think in Indonesia, we still have narrow understanding on sexual violation, like sexual abuse. When we say it, people only like think about opposite gender abusing another opposite gender. But in fact, that after this presentation, we have fully understanding about sexual abuse can be done by also women, by also like healthcare who have qualified, who have certification to do that, but they don't, they neglect that part of giving a consent and listening to the women. It should be noted, jadi teman-teman harus mungkin juga sama-sama mencatat ya, ternyata pelecehan seksual bisa dilakukan oleh sesama perempuan juga gitu, walaupun kita sebagai tenaga kesehatan mempunyai sertifikasi untuk melakukan kegiatan tersebut. Okay, once again, if you want to ask question, don't hesitate to raise your hand, okay? I want to give you another question here from GFOM. Okay, do you think that in today's era, where information can be easily accessed by women, by everyone, the forms of obstetric violence have also changed? What is the most noticeable difference compared to the past, or it's still the same?
I think that knowledge is power. And so women can learn a lot more by going online and can maybe realize that what they've experienced is potentially obstetric violence. And that has a lot of power in it, because then you've got a name for it. And I think it happened in the past, but when it's not spoken about, a bit like, you know, violence in the home, if it's not spoken about, then it's hard to recognize it in all the forms that it can be. So, for example, here in Australia, There's a beautiful midwife who's now retired, and she's written an excellent book. You must get her on to do a presentation for you. She's really good. She's written a book about caring for women after Caesarean. And she, her and I would meet each other at these conferences, and she read my paper, the obstetric violence paper. And then she came back to me and she realized that even though her children are now all grown up, that she experienced obstetric violence during her births. And she never realized what it was and what this big trauma that she'd been carrying all of her years for was, until she read the paper and could put a name to it. The good news is that once she realized that, she was able to go and get some therapy and support. And now she's trained herself, or she's gone to training in that same type of therapy, that so she can help more women who are realizing that it's happened. So it happened to her, but she didn't have words for it. And that's something that I think, because we can get this online, because we can talk about it in the arena, and that we can say it's not okay, as midwives, we can actually make a choice to stand with women and be advocates for women, advocates to reduce violence. We start it with our own practice. We think about everything that we do. Like I said, we do a pause. How can I make this safe for women? Every time you meet a woman. And then you model that and people see that. And then you talk about it. And it will have a rippling effect. So much so that obstetric violence will be something that women recognize, and then consume, and then healthcare providers recognize, and then we can actively look at changing it. So I think the benefit of these days is that we can get it out there. And some of you online, especially on your Instagram accounts, you have very large reaches. And so you can use your role as a public advocate and a midwife who's with women to actually advocate and educate on this topic, so that there can be healing for those women, but also preventing it from happening in the future. And we have to realize something you mentioned earlier, Honey, about the about midwives and clinicians not realizing it could be themselves as a woman, is that violence and abuse is all about power. And so power goes beyond gender. And in the health system, the woman is here and the healthcare provider is here, and doctors are kind of up here, the managers are up here. We have a patriarchal system. So when a woman is suffering obstetric violence, it can easily be done by anyone who is in that power dynamic above her, which can obviously mean midwives as well. Now, we might think, well, women, they just want us to do these things. They want us to kind of take over and make the decisions. But even if women are not aware of this at the moment, it has an impact on them. We have a saying, I don't know what your alternative is in Indonesia, or if you even have one, but I was told this in England by my own mother, that you lose your dignity at the door when you go in to have your baby. And I just absorbed that. I just took that because that's what my mum said. But actually, that's not right. No woman should be losing their dignity at the door of birthing room and then coming in to be disrespected and abused. That is not a good standard. I don't know if you have a similar saying in Indonesian. But we have to change that. And the more we talk about it and the more we recognize that, the more we can change that. And remember that slide with the bar graphs? We can change it, because midwifery continuity of care, relationship-based care, had lower levels of obstetric violence. So midwives, we have a big job to play in this.
Yeah, that's true. I think midwife is like a strategic healthcare strategic component to change this. Also like to advocate women, since we are based on the community, it's easier to approach women, also the family. It's really interesting since Indonesia has various of cultures and customs. I believe you've been in Sulawesi, right?
Yes.
Yeah. So when it turns to something contradict with with their beliefs in their culture, and it is like it could how to say it could lead to an obstetric violence also, I think, because when they feel not empowered or less voice toward their uh, toward their decisions, it could be also like be a violence. But how can we deal with that? Because it's so many aspects. Like when back then when you were in Sulawesi, how can you deal with that cultural things who can oppositely harm the health aspect?
I think firstly, you need midwives from those cultural groups, because then you can have that open communication and that relationship-based care. The other thing is we actually need to understand what obstetric violence is from Indonesian women's experiences. So with the birth experience study Indonesia, we will be able to find that out, because we'll have that question in the survey. Be interesting to see how it translates. And then we'll have those mistreatment index, and we'll have the birth trauma questions. There's lots of other questions as well, but those are the three on violence and abuse. And then hopefully if women do share, if they write down what their experience is, then we can get an understanding of what it's like, and maybe some of those cultural issues will also come through, and then that will help educate us. I always feel as a researcher, but also as a midwife, the way that we learn is we learn from the women that we're serving. And the women that we're serving, they are very good often at telling us what they need and what their wants are and what they're experiencing is. That's why I'm such a firm believer in the international collaboration of our study, because I can't say just what women are experiencing in Australia is the same for women in Indonesia or in Somaliland or in Zambia or in China or Taiwan. I could list 12 countries there. And that's why we need to get that information. And then once we've got that information, we then need to act on it. So once we got that information here in Australia, we didn't just publish the paper and say, see you later. We did media interviews. I did media interviews. I was on the radio speaking about it. I spoke to politicians, and this has led to an inquiry amongst other people in the field, but certainly our research has had an impact on creating this inquiry. So we have a job. First of all, we need to listen. We need to hear what it is that women's experiences are. We need to elevate that voice to be really important. We need to get it out there, and then we need to act on it. So the cultural issues is hard for me to really identify as a white, British-born woman. But when I have worked in different areas in Malaysia and Indonesia, and then in multicultural cities and hospitals, my biggest tactic has been to listen. And even better if you can create relationship-based care. So they know how you tick, you know how they work, and have an open curiosity. I would always want to know why, what it is. Tell me about your beliefs. Tell me what you're being told at home. And never to say they're wrong, but maybe give some education that might help the woman make a decision.
Okay, like it's true, like other than just do the research, we also need to think how to sound, how to make people understand about this issue, other than just throw it to the journal publisher and then it done. Yeah, I have also another question here, but is there any participant here wants to raise your hand? Okay. We have one from Zia Beentits. Okay, you can turn on your camera and also microphone.
Okay, thank you, Mbak Hani. I'm sorry I can turn on my camera because the signal is bad. Hello, Hazel.
Hi, Zia.
Okay, I really interested with this topic from Ruang Bidan, and my question is about episiotomy. I think all of the participant here is understand about episiotomy. How about episiotomy in the labor? Because the majority of intranatal care is still held an episiotomy. How to prevent this episiotomy and empower the mom and also the midwives to prevent the laceration of the rupture of the perineum.
Yeah.
That's all.
Okay.
Thank you.
Now, certainly episiotomy came up as a subcategory for women who, who said it was a form of obstetric violence. And in Australia, we worked very hard for many years to decrease our episiotomy rates, and now, unfortunately, they're on the rise again. But we can change that, and we do have very good evidence out there from the Cochrane systematic reviews that look at how to prevent third and fourth degree tears, because really the reason for an episiotomy, other than to make more room, is to prevent a very serious tear. But there are other things that we can do during that time. And I'm going to put my hand up right now and say, in all my years of midwifery, I never, ever needed to do an episiotomy. I never needed to. I would use other techniques instead. And I still had a very low, serious perineal tear rate. Now, what the evidence tells us is that the best preventative are warm compresses on the perineum. So instead of cutting it, we need to warm it. We get a warm compress. And my dear colleague, Professor Hannah Darling, has led the world with this research. And it's very simple. With a jug, half of it's hot water or very hot water, and then some cold on top of that, and then a cloth put into that so it's nice and warm, folded, and placing that on the perineum as it is stretching and as the head is crowning can help the woman breathe through that ring of fire, that really stinging time. And we know that that can actually prevent third and fourth degree tears. But it's a challenge when, as Ernie is saying, episiotomy is a routine standard procedure for primips, that it is then very difficult to change practice. But I challenge you to. The other thing is, if women are not in the lithotomy position, then it's not so easy to cut. Why? And we also know the lithotomy position is the worst position to give birth in. If you're lying flat on your back with your legs up in the stirrups, how do you use gravity? How do you allow the coccyx to move out the way? How do you encourage upright active birth? And if you've got more women in upright positions or leaning forward or squatting or kneeling, all the different positions, as long as it's upright and the coccyx is free, it makes it harder to do an episiotomy. And instead, you need to breathe the baby out. Rather than the coached pushing, rather than the hold your breath, and go, quick, take a breath in, that coached pushing, oh, it's exhausting. That coached pushing can also increase the use of episiotomies because you're worried, oh my gosh, I've got to get this baby out and you've got to push. When I was supporting women in labor, I would look at two places. One, the perineum, if I could see it, but most importantly, the woman's face. Because I would want her to have a relaxed jaw, not like this, but loose, to be able to breathe when the contractions are going and with the pushing, to push when she feels that she needs to push, not when other people tell her to push. And especially when there's that ring of fire, that crowning, to go ha, 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 and make it nice and slow, ha, 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 and let the perineum open like a flower. You will have women have small first and second degree tears. And sometimes they don't even need suturing. They can come together really nicely. It is a very vascular area that is very good at healing. But the power that we can give to women to actually slow that part down, allow the perineum to stretch, use warm compresses if she's on a land, not in water, use warm compresses, and slow that whole time down, and keep the scissors not next to you, but at the other side of the room, so they're not so easy to get. Maybe you can reduce those episiotomy rates. But it's not easy to change it. But I challenge you, one birth at a time, think, what can I do in this birth? How do I get her off the bed? How do I get her upright? Let's get those warm compresses and breathe her through it. And have a look at beautiful home birthing videos online, because there are so many of them, to really see how they're slowing their breathing and how they're doing their pushing without coached pushing. I hope that gives you a few ideas, Zia.
Okay, thank you, Hazel, for the incredible answer. I think we all here and the midwives still need knowledge. Yeah? It's like what you say. Thank you.
Thank you. Oh, I think Hani has frozen. She's coming back in. Or I can host. Has anybody got other questions? Oh, you're there.
Sorry, I just lost my signal for a while.
That's okay.
Is there any other question? Okay. In the G form also, like, we have another question here. Yeah, there is a question that I believe represent lots of midwife experience in Indonesia. So she asked, what do we do if we get a client who has never had contact with us before? So as healthcare providers, we don't know their history, and also have higher chance of causing violence.
I think as midwives, we are very skilled at building relationships in short periods of time, because we have to, don't we? We often will meet a woman in labor, we'll come on and we're allocated a room and we go in and we've got to try and build rapport straight away. But I think we can do that. And sometimes, you know, especially if it's, or whatever it is in labor, you can think about the hierarchy and the safety. Sit down next to the woman, have a chat. In our First Nations culture in Australia, they call that having a yarn. Find out about her in between contractions. Speak to the people that she's with. What are her hopes and dreams for this birth? What does she really want for this birth? Has she written a birth plan? If she's written a birth plan, read it. And then let her know what things you think are so good about it. I've had a look at your birth plan before I came in. I'm so impressed that you want to do this or this. And I'm going to do everything I can to help you. Smile. Be genuine. Spend time in the room. Don't just jump in 5 minutes and then go out. Actually be there. Offer physical support. You know, be there to hold and to hug and to touch and to put pressure on the back if she needs it, only if she gives you permission, of course. But I think we can do that. And you identify what you're there to do for the woman. Hi there, my name's Hazel. I've only just met you right now, but I'm so happy to be here caring for you. And I really want to make this a good experience for you. I've read your birth plan and I'm so impressed that you want to be upright and active during labor. And I've got the skills to help you. What would you like to do first? It says on your birth plan that you want to listen to music, but I can't hear any. Come on, let's get the music on. Let's do this. Who are the people that you've got with me today? And then speak to them and say, I'm so pleased to see you here, that you're supporting your partner. Like, what is it that you want to do from this? What are your fears? Find out, have a chat, check their comfort levels. Do you have water? Do you have a drink? Are you hungry? Is there anything I can do? And smiling and making that eye contact. And when you see that little bit of a change in the woman, that she's no longer comfortable doing what she's doing, don't just sit back and go, nah, oh well. Get in there and say, you look a bit uncomfortable. How about we try another position? How about we raise this bed up and you lean on it and you show the woman how to do it? This is how I mean. Let's lean on the bed and then let's sway your hips. And how does that feel? If I put pressure on your hips, does that feel good? And just tell me to go away if it doesn't help. And then stay there and spend that time. The more you give the woman, the more you give of your time and of your energy and of your kindness, the quicker that rapport will grow.
Wow, that's fantastic. Okay, I believe also like as a healthcare profession, we are have a chance to get a violation also. If we are the victim and experience this obstetric violence, what should we do after that? Should we like contact some of the authoritarian or please let.
So do you mean that through witnessing it, there's the impact of witnessing it, of seeing
Yeah,
it?
it could be when we witnessing it or we are the victim of that. So whenever if we bring it to us, I mean like if we think it could be done to us, we can also like tell everyone, if you experience this, you can report or what else, or should we create the, how to say it, like psychological support for them, the institution. Okay.
So the ongoing impact of witnessing obstetric violence, or maybe you've experienced it yourself when you were going through birth, obviously has an impact when you're working in it. And you can get burnout, you can get compassion fatigue, where it's hard to find compassion for the people you're caring for. And it's like having that cup, and once it's completely empty because of your own experiences, and you've witnessed something else and you've witnessed another one, and gets all the way to the bottom, you've got nothing that you can give. And I sometimes think that some of the poor behavior that we see from colleagues is because they've got nothing left to give. So we need to be aware of that ourselves. And I actually teach this to student midwives in their first semester of their degree, so that they can be aware of what it looks like. So for midwives, it can come out in a variety of different ways, but there can be some, mental health issues, the fear of going to work, the constant worry of what's going to happen, behaving more fear-based than not, bringing it home and, having a poor, impacting your relationships at home, feeling depressed, feeling anxious. When you find this happening, or even before that's happening, and you're starting to feel like this way, then you do need to reach out and get support. Here in Australia, we're very lucky. We've got a 24-hour helpline called Nurse Midwife Support that the government funds, because they know what a challenging job it is to be a nurse and a midwife. But other things that you can do in your own area is you can create peer support groups. So maybe having a group of you together that you can chat to about how you're feeling about it. If you've got serious, if it's really impacting you seriously, then you need to go and get psychological support, however that looks in your country, whether that's religious support or whether that is going to, to counselling, whatever is available, and whether or not you've got that through your hospital. There's no shame in getting help. And as much as we would say that to women, we would say to women if they're experiencing mental health issues, there's no shame in getting help. We have to have the same compassion for ourselves and say there's no shame in ourselves getting help. Next week, I'll talk about birth trauma, and I'll also talk about birth debriefing. And I'll touch on what debriefing looks like from the clinical perspective as well. So maybe some of those questions will be answered there too.
Yeah, hopefully in Indonesia we'll have better support in the future. Like, I believe the midwife here will also like carry the same energy to create the supportive environment also for our colleagues, not only for the mother, for us as a midwife also. I think that was the last question, Hazel. So yeah, we had a very fantastic discussion today, and so many amazing questions and insight that we can learn from you. So before we conclude,
can I ask a question? Can I ask a question? My question is, it's been a very tough presentation, a very tough topic to talk about, and it might hurt you in your head. It might be very difficult to process. So what I want you to put in the chat is tell me something that you're going to do for yourself today to take your mind off this, to make you feel a little bit better. What are you going to do? Are you going to go for a walk? Are you going to play with your children? Are you going to talk to your friends? Are you going to go shopping? What are you going to do for the rest of the day so that you're going to be feeling better? For Ernie, I think it'll be going to bed because she's in England. But for other people, what will you be doing for the rest of the day to make you feel better after today's presentation? I'm probably going to go for a walk, or I'm going to play a board game with my family because it's being a Saturday afternoon here. What are other people going to do?
Teman-teman bisa diisi chat box-nya setelah ini mau ngapain gitu biar healing, biar legaan sedikit pemikirannya habis kita mikir trauma-trauma ya. Silahkan diisi yuk. Mau kegiatan apa nih biar agak happy habis ini. Well, to be honest, I will go jogging, I think, in the afternoon. But after I attend my friend's wedding party, so I will have a lot of food. I will feel happier after this, definitely. Okay.
Oh, that sounds lovely, going to a wedding party. There's some of you going to go for lunch. You're going to continue work. Yeah. Sleep and eat well for Annie.
I'm going to see the bride. Yeah, I would like to have some lunch. Thank you, Hazel. We have few of it. Teman-teman bisa nih diisi dulu ya. Take a nap. That's very that's very helpful, definitely. Play with the boys.
Well, thank you for sharing them.
Okay. Okay, thank you guys. Before we conclude, I'd like to leave you with some key takeaways from today's webinar. The awareness to the issue of obstetric violence must be increased and start from oneself. So the participant who wants to discuss the same issue can contact Hazel and her colleague in Indonesia, which I think a few of us already know, Budiza from Unair. You can create a lot of projects related to this topic. And what can midwives do to support women to avoid this violence? Well, the language is everything, so you can make sure to convey a respectful language, empowering them with kind words and a very compassionate on it. And then you can encourage women to learn about the process they're going through. So Whenever the difficulties happen, you can also minimalize the hard communication during it. And then you can also change your attitude and change your old habits that have been passed down from the generation to generation. So you can be more sensitive to the needs of women and change your practice toward the women. Do the research, publish and expose it in the media. So let the whole world know about this matter. Next, women do not forget their birth experience. So they will carry the pain and the trauma for the rest of their life. And you as a midwife is an important element to create beautiful memory for them. Lastly, in every action, calm and stop for a while. And ask, how can we make this safe for their physical and mental? Be gentle toward their situation and communicate very well. Okay, I'd like to extend our deepest gratitude to our remarkable speaker, Dr. Hazel, for sharing her insight and experiences. I also want to mention our engaged and passionate participants. Thank you for your involvement. And I will return this to Midwife Anis.
Okay, thank you for Midwife Hani for leading the discussion. Okay, we have a photo session. I hope all of you can on camera. For the operator, we ask for your help. I count it from 1, 2. Okay. Okay, thank you so much for the moderator and the speaker. Thank you, Hazel. They are very inspiring and give us motivation to do better for the development of midwifery services in Indonesia. We hope you have learned and enjoyed this webinar. Once again, I would like to say thank you for the amazing participant for the discussion. On behalf of Ruang Bidan Indonesia, I apologize if there are any mistake happened during the webinar. Don't forget to follow our social media to put the story about this webinar and please kindly tag us. Don't forget to join our webinar next week. Jangan lupa untuk join, ada sesi ketiga kita. Topiknya nanti akan berbeda lagi dengan yang hari ini, jangan lupa join. Kemudian, thank you and let's meet in the next webinar session by Ruang Bidan Indonesia. Kurang lebihnya mohon maaf. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Thank you so much, Hazel. Thank you, everyone. See you next week.
Thank you.
See you next week. Thank you, Hazel.